2.
Recording in progress.
Good morning, everybody. My name is Chris Fraser. I'm here to kick off and chair our subgroup meeting today. Our Aging in Place Working Group has this subgroup, Social Determinants of Aging Well. We're looking at racial disparities and health equity. I'm thankful for all of you panelists who have joined here this morning. Just for a little background, in case any member of the public or others who are not official panelists are listening, I am one of the co-chairs for this committee. I am the Chief Operating Officer at Westside Family Healthcare, and I also serve on the board of directors for Christiana Care Home Health. And so what we'll do this morning is do a little bit of opening and welcome, let everybody introduce themselves. We're going to run through our minutes. We have a few members here from the great team at Disparity who are going to present for us: Brian Bailey, Alicia Stoneberger, and Julie Devlin. We'll do a little bit more introductions with them. Brian's our deputy director for the division. Julie has done a lot of work in planning and assists the director. And Alicia, background, I believe, in nutrition, and also working a lot in state and food, addressing food insecurity. We're going to hear from them in the third segment of our agenda here today. And then this committee really is tasked with diving into the discussion on racial disparities that exist in the state and social determinants. And from that, hopefully, by the end of this meeting, we will have some draft recommendations that we need to bring back to the larger working group, which will wrap up in April. So the really important work as well that needs to be done at the end here. We will be open for some public comment. We likely have some individuals who are not panelists who are listening in as well. So we'll have opportunity for all of you to contribute. And we'll wrap up. So I'm going to try to move quickly today because we do have some members who need to, or guests who need to drop off around 11. And so with that, let me turn and I'm going to go around my screen here on the Zoom and ask for the rest of you if you would help me with introductions for the rest of the team. So I'm going to start with Carolyn. Would you share, please?
Okay, I'm Carolyn Fredericks. I'm the director of the Modern Maturity Center in Dover.
Thank you so much. Thanks for being here this morning. And for all of you being here on a Friday and taking this time. Julie, you're next, please.
Sure. Hi, everyone. Again, my name is Julie Devlin. I am the executive assistant to the director and legal services developer at the Division of Services for Aging and Adults with Physical Disabilities.
Thank you, Julie. Appreciate you being here. Alicia.
Hi, I'm Alicia Stoneberger. Like Chris said, I'm actually a registered dietitian. I've been with Disparity in that role for actually close to 15 years now. I was in the long-term care section, and now I've moved over to community nutrition. So I have a giant background in all that the community and that the work group has been discussing.
Excellent. Thank you. Thanks for being our guest and for speaking this morning as well. Brian?
Good morning, everybody. I'm Brian Bailey, the Deputy Director for the Division of Services for Aging and Adults with Physical Disability, affectionately known as DSAPID. I work with Alicia and Julie, have oversight over fiscal performance, ISU, contracts, provider relations, things like that. So thanks for having me.
Wonderful. Thank you. Appreciate all three of you being here. Rob.
Hi, I'm Rob Lattin. I'm the Director of Government Affairs for Bayada Home Health Care, and I'm also the Legislative Chair for the Delaware Association for Home and Community Care.
Great. Thank you. Appreciate it. Allison?
Yes, I am Allison Sullivan. I am the owner of Home Instead. We are a non-medical home care provider in Newcastle County. I am also on the board of the Delaware Association for Home and Community Care.
Great. Thank you very much. Appreciate you being here. I believe that rounds out those who are guest speakers or panelists here. And like I said, there are probably others who are on and listening, and we would love to hear from you as well. We usually open that for public comment. I do on my screen, I do also see helping support our IT efforts, Eshawn. Thank you. I also see Taylor Hawk. Thank you, Taylor, for helping guide us through. I know you're going to guide us with our presentation. We'll also have Will Leskus, who's joining us as well. And we'll turn to Will to help us with some of our discussions later. Someone also from the General Assembly. I just really appreciate all of you guys, your support in making this meeting happen. Let me round out the first part of our agenda just by a little reminder. This weekend, I believe, if I have it right, is daylight savings time. I am looking forward to that. And it'll be interesting too to see where we all arrive to as we're talking about legislative recommendations. No, that's an interesting topic of discussion, but we've got a number of other things to dive into, but really looking forward to spring. So thank you. Our next topic on the agenda is a review of the previous meeting minutes. And for those of you who are not panelists on the group, I'll just give you a quick summary. Our meeting was last held on February 10th. We had a short meeting. We talked a little bit about our current state initiatives, work that's being done. We have, and you'll probably see in our recommendations, had a lot of discussion with this group about retaining our workforce that we need in order to make an impact on the social determinants of health. And know we have another subcommittee that's looking at that. We've talked about reimbursement needed for our providers. And we spent a good bit of time talking about a wonderful program, the Meals on Wheels program here in our state and the impact that it's had. We'll talk a little bit more about that this morning. We want to round out our discussion on food insecurity. And we also talked a good bit about volunteerism and the value that it plays, especially in this arena. So I would like to entertain a motion for our minutes approval from last meeting. Does anyone? Rob?
Motion.
Thank you. Do we have a second? Carolyn, thank you. All in favor? Thumbs up, say aye. Anybody abstaining, opposed? All right, well, minutes have passed. Does anybody have any corrections or notes on the minutes? Okay, wonderful. All right, thanks for letting me take care of that housekeeping. Right now, the portion of our program, we're on our third part of the agenda. We're going to turn it over to our team from Disapid, who's going to present, and then we'll continue the discussion about that. So Taylor, if you're still good with us, would you please put the presentation up and turn it over? Thank you.
Thanks, Taylor, and thanks, Chris. I'm going to kick it off talking about the meals program as it was pre-pandemic, and then we can talk a little bit about how it operates during the pandemic. Then I'll kick it over to Alicia to talk about some upstream services we were looking to add in, and Julie will finish out with dementia. This is a very high-level PowerPoint that we put together, and I know that we're not supposed to have our favorite children, but as far as programs go, this is my favorite. So I will dive into some things, and if I go down a rabbit hole, please pull me back out. But at the end, obviously ask any questions that you want. Can we go to the next slide, Taylor? Thanks. So Disapid offers this program, and so does Medicaid. They pretty much mirror each other, except Medicaid is obviously matched with federal dollars, so it's a little bit cheaper to provide a meal through Medicaid. They also do allow for 2 meals for some participants, whereas Disapid only allows for 1 meal. Now, the congregate part of the program is Disapid only. A congregate meal is provided to any person over the age of 60 for free, regardless of income, regardless of disability. Anybody who's over the age of 60 can walk into any one of our congregate centers and get a meal. There are 38 current congregate meal locations in our state. That's a lot. For the people on here who are unaware of the program, I'm sure that's a little bit stunning. Wow, 38, right? The majority are in Newcastle. I think we've got maybe 6 in Kent and 9 in Sussex. Right now, 30 of those are open. And, you know, just it's more of a personal type of feeling, but I just want to weigh the importance of the congregate meal. Obviously, the home delivered meals for our more vulnerable are important, but the congregate meals a gateway into so many other things. And I know we have Carolyn on here, and she's a great advocate for this program, and so is her center. But if you walk into the Modern Maturity Center to get a congregate meal, you're going to open yourself up to so many other possibilities. First, you're not sedentary, right? You're out, you're moving, you're socializing, you're doing what you're supposed to do. And then you can segue into so many other programs to keep you active. More of those upstream services that the SAPID wants to focus on. Switching over, the home delivered meal program for people ages 18 to 59 is available. For those with physical disability, again, if you're over the age of 60, you may be eligible for a home delivered meal. There is a criteria guide that we follow. Not everyone is eligible. I will say that the state of Delaware is one of few AAAs or SUAs that has no waiting list. That is due in part to JFC year over year providing plenty of funding for this program. So it's definitely something that the state should be proud of. Many other states have long, lengthy wait lists to get on this, and we do not, thanks to them. There are 4 providers. Newcastle County is City Fair, St. Anthony City Fair, Modern Maturity Center, obviously in Kent. Cheer has multiple locations as well down in Sussex, and there's a little sliver by the beach called Meals on Wheels Lewis Rehoboth, not to be confused with the actual Meals on Wheels nationwide program. Just to hint on that real quick, there is Meals on Wheels actually helps to fund right now some of the capital items that are needed by the providers, kitchen items, trucks, things like that. So when you donate to Meals on Wheels, that money does funnel down to the providers. It just doesn't provide for the actual meal at this moment. It can, if needed, if we were to have an explosion, and that's a bad word to use, I'm sorry. If we were to have a huge growth in the number of meals that we're supporting, and we needed to go to Meals on Wheels of America, they would support us in the funding of those meals. Just a few other things I wanted to hit on that aren't on the PowerPoint. Volunteerism, so important. The more volunteers we have, the less it costs for the meals, the more people that we can serve. So anybody on here, if you want to share the information, I'm sure that any of the providers would welcome you to deliver home delivered meals. And, you know, I can say from one of the people who has done it, and anybody on here who's done it, they'll tell you how rewarding it is. So please take the time to do that and share that information. We're always looking for volunteers. There aren't too many volunteers. And obviously through the pandemic, we did have some steadfast, wonderful people who stuck with us, but we did lose a lot of volunteers. We're looking to regain that stature and build that back up, but we're not there yet. One of the things about the program, Dietary Guidelines, these are funded through the Older Americans Act. We need to follow the dietary guidelines. I think we're on the year 2020 still. We'll switch to 2025 soon. It's one of the more difficult things that some of our dietitians need to deal with, in that they want to make the meal taste good and have people come into congregate centers and have people be happy at home as well, but they need to stay within guidelines. And I find that I've never had a bad meal at any of the centers I've been in, so I think that they do a tremendous job with that. Again, there's a funding mix. This money comes through the Older Americans Act and Administration for Community Living. It's about a 50-50 mix between that and the general fund that we use it for. Again, that's the reason there's no waiting list. If we only had our funding from ACL through the Older Americans Act, we would have a waiting list, just like 90% of the other people receiving this funding. But we're very fortunate in this state to this point to be able to support it with the general fund and be able to have no waiting list whatsoever. General stats, they've changed over the pandemic, but we serve 1 million meals for the last 3 or 4 years. That may or may not sound like a lot to you, because if you compare it to, say, a food bank number, just remember that the majority of those 1 million meals are cooked and delivered. They're not sitting in the box. They don't require somebody to throw them in a microwave or cook them on a stove. It's already done for them. That's a huge undertaking. Some of our providers cook the meals in their own kitchens. Some of them outsource it, like City Fair. They go to Delaware Gourmet. They make it. They ship it for them the morning of the delivery. Just a shout out to our providers. I know Carolyn's on here. The other three I don't believe are. Through the pandemic, we were this close numerous times to having to close kitchens due to the virus, and none of the providers ever did. And we did have plans in place if it were to happen, but we're very fortunate, knocking on wood, to this point that it did not happen. It's definitely a point of emphasis moving forward that we have protocols in place to offset that problem if we had to shut down a kitchen, so that our most vulnerable who need the home delivered meals would still get them. We had emergency meals out there. They're more of the box type of meals that you use during a snowstorm when we can't get out to deliver. And we just delivered a bunch of those. Sometimes we'd cook 2 meals, freeze a meal. They can reheat it the next day. And we had other providers ready and willing to chip in to fill out those geographic areas that might have been hurt by the pandemic and the shutting down of one of the kitchens. I'm not the best and versed at talking about SNAP or the food bank, but just keep in mind that this is one available program. The food bank has been a tremendous partner throughout the pandemic. They brought food to us and they've delivered it to the same people that we are also providing home delivered meals to. People over the age of 60 in Delaware are able to go through, and I'll get the acronym wrong, it's like the CFSP, the Commodity Food Service Program, I think. Based on income, they are eligible for free food through the food bank. Mm-hmm. If anyone needs to be aware of that, I would sure look that up on their website. I realize that I've talked probably a little bit more than I should with the time that we have, but I think it's better that I stop now and ask if you have any questions before we move on to Alicia. Otherwise, there'll be too much information to remember all the questions that you have. Anybody, questions? This is my favorite topic. Please ask me questions.
All right, thank you for the presentation. Is there a rough estimate of how many volunteers we have with these programs?
That's a really good question, Chris, and I don't know the answer to it. Based on the routes in my head of each of the providers, it's in the hundreds. Maybe it's between 200 and 300, I would think, at any given time. So the one thing that hurt us in Newcastle especially was big business in the city. They were continually sending down their professionals to do this during the day. And when the pandemic hit, they completely went away. So we had to fight that. And I'm sure Carolyn can talk a little bit about her volunteers down at Maturity Center that are incredible. If you're ever there at between 9:30 and 10 during the week, you'll see that thing in motion. And it's just a beautiful thing to see.
Thank you.
I'm sorry.
Go ahead.
Yeah.
I was just going to add that Maturity Center throughout Kent County has about 150 volunteers. We have many, many routes, but we're still looking for volunteers. And I'll be talking about that situation a little bit later as well.
Thanks so much for all the information, Brian. It's really helpful, and especially for some of us who maybe don't have as much interaction with food security issues or Meals on Wheels per se. I don't really have a question so much as I'd be remiss if I didn't kind of point out one thing that you said that has been somewhat of an underlying discussion, as Chris mentioned before, but you mentioned a lot of the success of this program, in addition to the volunteerism and the political will, is that JFC funds it pretty robustly, according to you. And I'd be remiss if I didn't, for the betterment of this conversation, Chris, in line with some of our others, but that is generally the ask or the kind of, I don't want to say one size fits all solution, but a problem with aging in place generally is that funding is not provided year on year at levels that it requires in order to be successful. So I just want to point that out because, you know, if the SAPID is willing to go on record and admit that, it's worth us, you know, supporting that sentiment. So thanks, Brian, for saying as much.
Okay, so we are supported through the general fund and the JFC. It's chosen through those funds to support meals. We could attempt to spend the money down a different avenue, but like right now, with personal care and things like that, we simply don't have, and I don't want to go down this rabbit hole either, but we don't have the available resources. And I know you guys are talking about this even through your SDOH group, that you don't have the ample employees, co-workers, the CNAs, the HHAs to do that work. So whereas we do have funding available for that, we can't utilize it right now because we don't have the people to do it. That's all I'll go, as far as I'll go with that, Rob, but thanks.
Yeah, I mean, I appreciate all that, but I would say you're at least in a position to have the funding, whereas many, you know, a lot of these Medicaid rates, for instance, have gone up once in 15 years, maybe, you know, once in 10 years. So, and the problems related to workforce are a little different from industry to industry in the sense of whether people are out there or not, or, you know, competition, et cetera. But, you know, your point's well taken. I always go out of my way to point it out because it affects everybody, funding issues.
Yes, sir. If I could just, we'll move on. And if you think of more questions during this, but if I had to pick the one thing that folks don't pick up on, and not necessarily this group, obviously, but in general, and it hasn't been great through the pandemic because the congregate meal sites have had to close down and reopen and close down and reopen. But these sites are as clean as possible right now. And they are obviously the gateway to the younger aging population to do what's right in their health right now. And if a meal is free and you can associate yourself with friends and you can get into one of these centers or maturity centers and age properly for free, and there are donations and you can donate, but you're not obligated to. That's what I would press. You know, if you have family, friends, neighbors that are over the age of 60 and you feel like they're on the edge and they're teetering, they're still mobile and they're able to get out, I would press upon them to look for one of these locations and to get out and to stay active, to get a free meal, to socialize, because these sites are not utilized nearly as much as they should be. And if you saw the trend, and I don't have it in front of me, but the congregate meals have dropped year over year over year, they dropped. Well, our aging population in the state of Delaware is growing. So it's exacerbated. How can you have a growing aging population, yet your congregate meal sites are declining? And some of them might get our aesthetics, or maybe you don't have a comfort level, depending on which one it is. And there's, you know, some are better than others, I'm sure. But I promise you that they're all serving very, I want to say adequate, but it doesn't seem like it's proper because they all meet the dietary requirements, but they're good meals and they're good for you, and they're either free or inexpensive, depending on whether or not you donate. So I would press upon everyone on this call that's something that I would at least share with as many people as possible. So thanks for the time, and I'll stick around for any questions you have after Alicia's presentation or Julie's.
All right, thank you so much. I did have one quick question for you, just in the context of our meeting, and I appreciate the comments, Carolyn and Rob, that you guys contributed. One of the things that you had mentioned, I think it'll go to our next presentation with Alicia, like you had mentioned, is getting upstream. And as we're going to talk later about social determinants and the communities where these programs are needed, I think that's going to, well, Alicia, I don't want to steal any of your thunder, but I think, Brian, when you said that about getting upstream is so important. And I wonder as well, you know, even as we're talking about resources and where, you know, the state needs to make decisions to put resources, are there any congregate settings that are missing? Are there any communities where Meals on Wheels is not serving that we might, as a group, make some recommendations to the legislator to say? So that I'll stop there.
Yeah, and for my team, anybody who wants to elaborate, please do. For home delivered meals, Chris, no, we cover the state. Distance isn't an issue. I mean, in Sussex, we'd obviously have the biggest problem. And between Cheer and Meals on Wheels Lewis for Hobart, they cover everybody. No one is turned away due to distance. Congregate Meals, I want to say we do a fantastic job. There are, and the numbers have changed a little bit through the pandemic, but there are about 28 providers in Newcastle County alone. Wait, that's wrong. It's 26 providers alone. So that's a lot of providers in just, in Newcastle County. And then Kent County, I believe, is 6. It seems like there's pretty good coverage. And Sussex, there's 9 with 8 open right now. There could be a place, in southern Delaware that can't get to Greenwood Center, maybe. And distance is an issue, but if you're able to drive, I don't think that, given the size of our state, that it's been an issue. But it's definitely something to look at between transportation and getting to a site if you want to. So maybe you can't drive anymore, but you're still mobile and you can get transportation involved. That would definitely be a social determinant I'd be concerned with. But I think overall, it's a pretty good job. So I don't know if Julie or Alicia want to add anything.
Okay, thank you.
So this is Alicia, and yes, even though we have coverage in certain areas, and I read this in some of the meetings, I think, of one of the other subgroups, some of the issue is really on community population and trust, and whether or not some of those populations are historically going to visit some of our senior centers, like Western Sussex areas. We have certain groups of population that maybe don't traditionally go to senior centers, maybe some more insular family type things. So you do see that. So there are certain areas that it's not that they're underserved, it's that they're somewhat underutilized. So you just don't have that population breakthrough. And if we bring up my presentation, some of that is those are the exact issues that we are trying to address, that we've noticed, and that we need to think of some new and innovative ways to bring some of these individuals into the fold. And then again, introduce them to the items that we can provide, and then kind of let it blossom from there.
Thank you. Do you want to progress to the next slide, Alicia?
Yeah.
Yes, please.
I'll just add, as doing that, just a quick percentage. So with who we served with home delivered meals last year, it was 26% African American, 68% white, and then 5% other and 1% unknown. But I would think absolutely in the congregate centers, we do not break through, the great term that Alicia just used, to the Hispanic population in Sussex. We don't break through to them. So that could be a useful topic maybe. Yeah, but otherwise it's in line other than that.
Got it. Thank you.
And that's exactly who I was getting at, Brian. And Brian and I have had discussions on this previously, obviously, which is sort of what started what I'm going to talk about now, which is what we're calling the SHINE program. Mostly because programs do well if they have a nifty acronym. They're easier to market. They're easier for people to remember. Like, you're not going to remember, like, for instance, our acronym, DSAPID. You remember that much more than you remember the whole long thing. So SHINE really stands for the Senior Health Innovation and Nutrition Education Program, which in itself is a mouthful. So SHINE, what we're really aiming to do is, as Brian had alluded to, Delaware's senior population is growing by leaps and bounds. Looking at some population statistics, we're around 10th in the nation for growth, and that is for 65 years of age and older, because that's what the Census Bureau really counts. So in order to get population statistics for 60 and over, which is what our program covers, you have to do a whole bunch of math that is way beyond my capabilities. However, on the flip side, we are 38th in the nation for the percentage of population of 65 and over who have been diagnosed with obesity and or a lack of physical activity. Okay, and another statistics that I did not include, which sort of the unhealthiness so to say, of this population is that then that progresses to chronic disease. And we are 41st in the nation for prevalence of 4+ chronic diseases in 65 and over population. And what does that do? That greatly inhibits our ability to age in place with having that many chronic diseases. You add medication, and dementia and Alzheimer's related diseases are included in that chronic disease panel. So even though we have a large 65 and over population, they are by nature unhealthy, and that's a problem. And as they continue to age, and our 85 and over percentages are huge, they will continue to be more and more unhealthy as they age, just given what we see about them now. So what we're going to try and do with a program like this is we're going to try and provide them with, and their caregivers as well, and I think that's a very important population to add to this as caregivers, with health and wellness programs, evidence-based programming, resources and education in a variety of different formats, okay? And, you know, providing this information not in our typical, you know, senior center, you know, not in maybe one of our partners, but looking forward to developing other partnerships, maybe some of those communities that we don't have as big an impact in generally our Western Sussex Hispanic community that we don't make a big enough impact to. Faith-based communities that are so important to many, looking for those types of resources, you know, access to all those individuals that we may not hit as well, or maybe, you know, again, when we're thinking of our younger aging population, you know, our 60 to 70, people that might not be traditionally comfortable with the idea of something like a senior center, if we can introduce them to evidence-based programming, we can drive them in there. And then once you're in many of these places, you're hooked. Because you don't think that, you know, a place like Modern Maturity Center is going to look and do all the things that it does until you walk in, okay? You walk in and you see this, you know, they have this glorious event space that's beautiful. You know, they have a gym and a pool, and they do all kinds of fitness classes, and it's hopping when you go in there constantly. There's never a dull moment there. So, and the others are much the same. So these types of programs are things that we can do to get people in the door in some of our congregate settings. And so going into what we're really going to try and do, I think, first is rely on some evidence-based programming. And the beauty of evidence-based programming is that by the time it gets to the point where it's an approved program, providers and such have already done all the work for us, okay? The program has been developed, it's been tested, and it's been proven, okay, to promote health and prevent disease among older adults, specifically the older adult evidence-based programming. Participants are able to build their own skills to take control of their health. And many of them use a behavioral health model where it sort of focuses on getting individuals to learn how to make their own successive changes. Okay, so we help them to make one change, and typically tend to notice that that first change in a positive light sort of sets off a chain reaction to then be able to take control of their own health and to know which choices to make. And then be able to use those people as potentially mentors to help other individuals, because, you know, you tend to pay attention and tend to be most comfortable around your own, your own social group. So whether that be, people of the same ethnic background, the same age and such, okay, using these people as, as what they should, as mentors. And the other beauty, and I hate to say the beauty of COVID, but there have been a few things that we've seen that have come along and have forced change, is that almost all of these programs are now offered in a variety of formats, in person, online, and some that I like a lot, and it sounds archaic, but the telephone option, especially for some of those individuals that we're speaking of that have lack of transportation, the telephone method is great. Because sometimes it's just that weekly contact, and it doesn't need to always be in person. That is helpful. especially to some of those individuals who are maybe not comfortable, initially, the telephone is kind of an icebreaker. And we're looking to combine several programs, and I believe we're going to start potentially with one program per county. And we're really looking at right now where we feel, the last thing that we want to do is start out with it. Some programs are super complicated, some are not. So we don't want to obviously put ourselves in a position where we're going to fail, but we want to make sure that we're picking a program that is something that we can administer appropriately and that we think that participants will really enjoy. Because honestly, the instant that you say like get healthy or whatever, people instantly think weight loss and they turn around and they run away in droves because people just don't want to talk about like that. So we're really going to focus on healthy behaviors instead, and the programs are going to be somewhat all-encompassing, not just focusing on one particular item. But again, they're really going to hinge on these health and wellness-based partnerships that we're looking to attain statewide, really, because we really like for, obviously, using our current partners, but using some of their facilities really as well to host programs. DPH does the same thing right now with the chronic disease prevention programs and the fall prevention programs. A lot of these are in the same sort of light and really just combine upon a whole bunch of different topics. So I think that's basically it. I'm guessing there will probably be some questions about this. And this is really actually just phase one of this program. I have a whole bunch of different, potential topics along down the road, but they really rely on getting some of this initial stuff up in place because, next phases would really need data. Okay, we would need to see what works, what doesn't, who we're hitting, who we're not, where we're succeeding, where we're not, in order to really kind of guide how it would continue to go. So please feel free to add any questions or comments.
Questions from the panel? Thank you, Alicia. Appreciate your presentation. So that you said this is phase one, so I do have a question. Are you rolling this out with partners and when, I guess, timeframe for phase one?
There's no definitive date. We're looking at right now choosing the specific evidence-based programming that we want to put out there. And in the beginning, they really can be done with very few individuals. In fact, I'll probably be spearheading a good bit of it. But that's really the very first start, is actually just determining which programs we think will work where, whether or not we want to choose the same for all three or whether or not we want to vary it up. But we're likely going to go with a combination of a couple of programs per county. Okay. And then once we see that they've gone in place, then we're really going to hit on obtaining some, we have a bunch of community partners as they are right now, but, typically they're more focused to some of our other types of services, personal care, other things that we do, home health, all that kind of stuff, not necessarily as much towards prevention and health and that type of stuff. And that's where we're really going to try and, guide this into rethinking what we do and how we provide these services.
Thanks. Looks like Carolyn, you have a comment. Brian as well. Carolyn?
Brian can probably answer this question. As I'm listening to the presentation here, I'm wondering if you've had your meeting yet with the Education, Health, and Research Institute, because they have applied for a grant through ACL, and the grant is exactly for this, for chronic disease studies, and it's going to piggyback onto the We Care program that we already have in place. It's going to be working with those homebounds. I know that there was a meeting set up with the division, but I think that was when we had, when COVID was raging or something, and so that had to be postponed. but I mean, they're talking about basically doing the same thing that you're talking about doing. And I see a great opportunity there for a partnership.
Carolyn, we're meeting with them at the end of the month, but we did a letter of support for that grant. So we are aware of it and we plan to partner with them.
Thank you. That's great. And also the We Care program is now partnering with the American Heart Association to get equipment into the homes of those that need it to assess their blood pressure rates and everything. So we're growing that program a little at a time, but we're so concerned about the chronic disease and educating them and everything. So I see a great opportunity for a partnership there. Thank you.
Thanks, Carolyn. Brian, were you going to add anything?
No, I was going to just talk about the timing with Alicia and everything, but she cleared it up pretty well. So we're all set. Thank you, Chris.
Thank you. Appreciate it. Okay. Many of you probably saw, and I just want to thank Will, who's now our host and guiding us through, who took the handoff from Taylor. Will, welcome. We're glad you're here. And we're going to try to round out the rest of the presentation. Julie, are you ready for the handoff?
I am ready. And yep. So I'm going to talk about dementia slides. Brian said that nutrition is probably one of his favorite things to talk about. Dementia and legal services are mine. So nice rounded out presentation. So our division was very lucky to receive a federal grant in 2015 to expand our dementia services in Delaware. We named it the Alzheimer's Disease Initiative, and it ran until 2019. And we expanded or started a lot of different programs. One of them was a pilot sensory technology program. So we provided in-home technology to monitor someone with dementia, and so that their caregiver could check on them. And it was more than just a fall prevention. We already have that in our division. It was cameras, alerts on doors, alerts on stoves if someone were to turn on the stove and leave it on, things like that. And so we worked with a company to help us kind of develop a menu of different technology that the individuals participating could choose from. As you can imagine, it was a pretty expensive program, so we unfortunately did not continue it as a division, but recognized the importance of such technology in the home. And so that we provide participants that come in through the doors through DSAPIT with the opportunity to learn about that technology and give them the provider who had it if they're interested in it. We also did a caregiving program called Savvy Caregiver. Like Alicia talked about, evidence-based programs are really important, and this is one of the evidence-based programs we've introduced in the state. It is a education and a support group type program over a number of sessions, 2 hours each. And we work with our caregiver resource centers throughout the state to implement this program. And so we had East Seals, Wilmington Senior Center, Newark Senior Center, Modern Maturity, and Cheer all do this program where they would bring people together and find out about the progression of dementia. And as a caregiver, how can they work with their loved one to kind of not mitigate the behaviors of dementia, but really work with it so it's less of a burden on the caregiver. And many of our caregiver resource centers continue to do that program. They've been able to figure out how to do it during COVID virtually, which has been fantastic. And so we're really excited that they still offer that program. We also added money to our lifespan respite program, which provides vouchers for caregivers to take some time off and pay somebody else to come into the home and care for their loved one. We did a lot of community integration services programs. We added to our community living program. Typically, that program has been for people with disabilities to go out into the community. They're provided transportation, and they get to decide, what they want to do in the community. I want to go to the mall. I want to go play, or I want to go to a church support group, something like that. And we added a component where people with dementia could also participate in that program, and their caregivers could come with them as well. One of the big things that we did through the Alzheimer's Disease Initiative is provide a lot of partner training. So all of our providers are contracted providers through the state. We're given the opportunity to participate in a number of trainings through the Alzheimer's Association that we put on over, I think we did 3 or 4 trainings for all of our providers. And then we did continuous training as well. And then we did intensive training for legal services providers as well. So the entire elder law section of the Delaware State Bar received 2 separate trainings over a 3-year period through the American Bar Association, Alzheimer's Association, the Swank Memory Care Center, and about dementia and how to really work with clients who have dementia. And so that was really helpful. And one of the trainings that the Alzheimer's Association did was a train the trainer, and so that we could sustain that training. And then our internal training unit in Disparity also took it, so they could continue that training with our own staff. And then lastly, with that program, we expanded legal services. And so we worked after the elder law section did all this great training. We worked with them to develop a program where people get free consultations at those private attorneys to get their legal needs arranged. So if you were diagnosed with dementia, you could go to them and do estate planning, figure out a power of attorney, a healthcare surrogate, everything up front. And so when you were further in the throes of dementia, everything was already settled and your family didn't have to worry about it. And that is something that we still continue to do. We have a legal services program through the Community Legal Aid Society in Delaware. And so they provide free legal services for people 60 and older, and we still promote that program. So as you can see, over the 4 years of that program, we've provided over 34,000 hours of direct services to individuals, which is pretty remarkable for a federal grant. We typically don't, I would say, get things up and running, but we were doing so much and we had such great partners that we were able to provide such great direct services. And a lot of the things continue on to this day. And so that grant really came out of a lot of effort from a lot of our community partners through a state plan to address Alzheimer's and related dementias in the state, which was implemented in, I believe, 2013, 2014. We've now implemented that plan through the division's state plan on aging. So a lot of the things that were in that plan, the goals, continue on to this day. And the next couple of things I'm going to talk about are a direct result of that. First is the Delaware Center for Alzheimer's Disease and Related Dementias, or DCARD. It is an online hub of dementia resources. So we've worked with the Alzheimer's Association, Delaware State University, and University of Delaware to produce this website, and it's dcard.org. And it is, I would say it's in its infancy because it was launched right before COVID, as a lot of these things happen to be that we'll be talking about. But it is a great one-stop shop for Alzheimer's and dementia resources in Delaware, as well as the research that is happening at the university level. Delaware State University is doing some pretty impressive stuff around brain health. And so that kind of information is all right on that website. And we're hoping to build that website up even further so it's easier for people to navigate, especially, you hear, your doctor says, "I'm sorry, I think you have dementia." Well, what do you do? And so this website hopefully helps answer some of those questions of what people can do, because it feels like a very helpless and hopeless situation when you get diagnosed. But we want it to be more uplifting than that. And so some of the other things we're working on really get at that upstream that we've been talking about. That's kind of what we're doing when it comes to the dementia services. So we've also implemented a caregiving coaching program called the Resources Enhancing Alzheimer's Caregiver Health, or REACH program. It's an evidence-based program through the Rosalind Carter Institute, where we have 4 coaches in our division that are working internally with our caregivers. It's more of an intense program than Savvy Caregiver. It is 12 sessions, one-on-one, to talk about caregiving modifications that people can do. And the program has really shown that the burden of caregiving for someone with dementia is lessened because of this program. And so the hope is, and we're in the middle of doing this right now, so it's going to take some time, maybe like a year or two, but offer it to the community. Swank Memory Care Center has already approached us about being a funnel to us because they see most of the people, at least upstate, who are diagnosed with dementia, that they could funnel caregivers straight to this program. And so we're currently building it out. We're hoping to get 2 more coaches on our staff and really build up a dementia arm of our division. And that goes to the Dementia and Caregiving Coordinator. We're actively hiring for that position right now as a division. And that person really will be leading the charge and being the subject matter expert for dementia and caregiving in our division. And so they'll be out there talking about REACH and some of the other services that we offer as a division, D-Card, and then Dementia Friendly Delaware, which I will get to. But we're really hoping that the REACH program can be grown under this new position because it's really such an impactful program. We've had a couple of people go through it. It launched the week that COVID started. And so we haven't had a lot of people go through the program, but the people who have really found it to be very beneficial to their caregiving, so much so that they had thoughts of institutionalizing their loved one with dementia, and this program helped them to delay that institutionalization. And so the person with dementia was able to continue to age in place in a home setting versus in a long-term care facility, which is wonderful. That we've been able to give the tools to the caregiver that they need in order to manage caregiving. So the coordinator is going to do a lot of outreach, which right now, our division, you can see we all have a lot of different jobs. We don't have people dedicated to outreach. So this person is going to be really doing a lot of the outreach related to dementia services. And their number one priority is really going to be relaunching Dementia Friendly Delaware. So one of the other things we launched right before COVID was this program. And this really is bringing together partners from all different sectors of the community to make our state and how our state operates more friendly for people with dementia. And so it's as simple as a restaurant having large print menus or a quiet area, visible signs at banks that are easier to see, specific lighting or floor tile patterns, people from all different sectors recognizing the environment that they create affects people with dementia and their caregivers. And so really understanding what different businesses, organizations, and agencies can do, including training and working with their own employees to support them if they're in the caregiving or dementia journey. And so this coordinator is going to help relaunch that. We have a lot of great partners already on board, and the Lieutenant Governor is very committed to making sure that this program is a success in our state and as our way. So from our perspective, we're going to help working with the Alzheimer's Association and some of our other partners, provide training to all these different sectors. And I think our biggest ask from our community partners, including all of you, is to join us in this effort and become champions of this effort. We really need help connecting to all the different businesses and organizations and things like that we typically don't work with. And we want to work with them to ensure that they get the proper training and that they're committed to this effort so that people with dementia and their caregivers can age in place longer in Delaware and thrive. It's all about, thriving and being healthy. And that's what we're after in this effort. So that's a very high level overview, but we're really committed to it. And I think also, I just want to add that from the federal level, our partners at the Administration for Community Living are very interested in looking at the upstream services and healthy living, and dementia-friendly and age-friendly efforts are definitely part of that. They're also, as it pertains to this group and social determinants of health, very interested in how equity and inclusion are rolled out in different states. And so we have a state plan on aging, I mentioned it earlier, that runs till 2024. And in that state plan, once we have to re-up, but we have to do it every 4 years, we will have to talk about how we are including equity, diversity, inclusion in the efforts that we do to roll out the Older Americans Act, which is, as Brian said, it's our funding source on the federal level, but it's also how we do business. And so, you know, the recommendations that come out of this group will help us in determining that, because we'll start planning the state plan on aging probably early 2023. It's a very long process where we get a lot of feedback from our community. Carolyn has been a big part of those stakeholder engagement sessions related to the state plan on aging. And she also sits on our council. So, but so we definitely want feedback on that, because we want to make sure that we are hearing what the need is and that we're addressing it in that state plan. So I'll leave it at that. And if you have questions, I'm happy to answer them. Yes, Carolyn.
Yes.
I'm sorry, but as the questions come up, I just feel like I need to share. I was wondering if, Julie, if you know that we have a relationship right now with Christiana Care that does virtual sessions here at the Modern Maturity Center with the Swank Memory Center. So people do not have to go upstate. They can come right to the Modern Maturity Center. Christiana Care has a staff person here, and they link them right up with Swank. So that fits right in with what you're saying. So I just want to make sure you knew about that. Yeah, that's great. And that's, you know, with what Alicia was saying, one of the silver linings of COVID, we've been able to do things in a virtual world to make it more accessible for people. So that's fantastic to hear.
Thank you, Carolyn. Julie, thank you so much for rounding out the presentation. Like you had said, I do want to thank you and also the team at Disparity for all the hats that you do wear. I think you alluded to that and this really important work that you're doing. I think, Brian, you do have to leave coming up at 11.
Yes, sir.
Is that right? So I didn't know if you had any other comments, but my question too at the same time, I usually say something and make a question at the same time. So I'm sorry. So Julie, I was hoping you are staying on for the rest of the time with this. Okay. Well, I'll stop there. And then Brian, anything you would like to conclude?
Thank you. Thank you for having us. I know that it took an hour and they were just still overviews. Disparity obviously does a ton of work. And like Julie said, we haven't so much had what I would call subject matter experts or people out in the field advocating for these programs. So they might flounder a little bit without having a point person, but we are trying to do that now, especially with dementia and caregiving. We will get a point person and we will make these things happen because they're only growing. You know, the caregiver subject is out there. I'm sure it's part of the social determinants of health as well. Any way that we can support that, we certainly will. And I'm very confident that Julie and Alicia will be able to answer any questions that come up through the rest of the meeting.
Great. Thank you, Brian. Thanks for your service for the state, and appreciate you joining us when you have to jump off. Thank you.
Thanks, everybody.
Julie, did you have any anything else that you want to add? I did have a question for you, but I'll give you a second there.
No, I mean, I think that's it. We're just, you know, again, thanks for allowing us to present. And like Brian said, we love to talk about what we do. So when we get the opportunity, we're going to take it. So.
Okay. Well, we know we'll be working too with Melissa, and, you know, as I mentioned at the top of our meeting here, we need to have some draft recommendations to our larger working group. So we're going to be looking to you and Brian, Melissa for that. To our team, I did email some of that for consideration, and I'm going to hold my question because I don't want to steal Will's thunder. But well, no, I won't. I'll put my question out there, and then I think I'm going to turn to Will for the next segment. And Will, you were right. We should have gone a longer meeting today because there's a lot of great stuff here. I think we do have till 11:30, but Julie, I hope that you would help inform us as Will helps us walk through our next section on where you see opportunities where there may be disparities that exist. And specifically, as we're talking about dementia-friendly Delaware, I think in some of the information that we're going to discuss next that Will, I hope you'll present, will guide us to see that there are some areas, I think. And Julie, is there a quick, there are some communities, there are some maybe areas of our state, there are, like you had mentioned, some big work to be done in ensuring health equity, especially as we look at different disparities. Would you echo that, or?
Yeah, I definitely would. And I think Alicia touched on some of it in her part of the presentation, but we know that there are higher rates of dementia among minorities, especially in our state. And Will's information that he sent out talked about that. And I think for at least the services that we've offered, we collect data on it, and we're just not getting people from diverse backgrounds as we would like in our services. And so figuring out how to outreach them and get trusted people to talk about the program I wouldn't say it has been difficult. It's just been hard for us because we're the state, and so we need to do a better job working with faith-based communities, especially when we're talking about the African American community, because we know that that's a trusted place. We've learned a lot because of COVID-19 and getting the vaccine out, and so working with our partners at Public Health and our Secretary's office has really helped us kind of lay some of the groundwork of how we can go about doing that. But it's really finding trusted individuals in the community who can relay the message about what services that we offer, and that the services are good services that are helpful services. There's a lot of distrust of government services, and we don't want that. We don't want them to think that we're the bad, the scary bad people that are going to turn them in for something. Like we're not doing. Our goal is really to support them and make sure that people can live healthy lives well into their aging years.
Great, thank you. I appreciate that.
I have a quick question.
Yes, Allison.
Are you guys, do you have any plans of how to, obviously having a network that really can, particularly with dementia services, get the word out. Do you have plans to partner with any providers in the community or other ways, just to give yourself a more broad platform to get these services out there? How are you working with given that so many services for people who have dementia are provided by private companies, private businesses, do you have plans to kind of work with any, community resources in that sense?
Yeah, so we have a really great partnership with the Alzheimer's Association. They're going to be launching, I wish I could give you the time frame, but they're working on it now, an early detection campaign for Alzheimer's that we are working with them on. And that's going to point to some of the resources in our state. And then we also work with our contracted providers like Modern Maturity Center, who offer lots of great dementia resources through their center. And so we work with those. We don't have, besides Reach and Savvy, we don't have specific programming right now for people with dementia. And of course, Reach and Savvy are for their caregivers. But that's something that with the Dementia and Caregiving Coordinator could change. So I think that our leadership is open to looking at new partnerships and doing things like that. But it remains to be seen right now. So right now, our focus is really on outreach because we know that's where we lack. And we've heard it from not just the Aging in Place work group, but other work groups and task forces that we really need to beef up our outreach on things.
Yeah.
Okay, thank you for that question, Allison. Thank Julie. Will, you're our host right now, and
good morning.
Good morning, and Will, I hope you heard me. You were right. So we've spent a lot of time, but we have a big dive, and you provided an excellent memo. I want to thank you to our team here. For those of you who are listening and not panelists, we could certainly provide the work that Will has done. Our next segment of the agenda, this committee is about diving into racial and ethnic disparities and ensuring health equity. And so, Will, I want to thank you for that. You highlighted in your memo that we have significant disparities that we've been talking about here in our state, similar to our nation, and those have implications for individuals' ability to successfully age in place. So I hope I'm not putting you too much on the spot, but wondered if you could help us walk through that memo, and especially kind of, Julie, what you were saying. I think this will help inform the discussions we've had and where we might make recommendations. So Will, turn it over to you, please.
Thank you, Chris. Can everybody see the screen?
Yes, thank you.
All right, perfect. Yeah, so this is largely inspired by that large collection of resources provided by Julia O'Hanlon, who's from the University of Delaware, and tried to distill some major trends and where kind of examples of where these disparities lie in relation to that priority summary or survey that went out at the beginning of the process. So identified three major areas. First, racial disparity in relation to economic factors. In this sense, taking it from two perspectives, one is on an income and then the other on an asset level. And these are fairly high level. I mean, there's more elaborate measures, but I think per capita income and asset holdings are pretty good indicators of where things are. So this first figure shows per capita income. The top line shows by racial group in Delaware, and then the bottom line is the U.S. average. So actually interesting to note in terms of so Delaware's Hispanic population is actually significantly lower than the national average, whereas the Black and white populations are higher than the national average, which makes that point about, I guess, outreach to the Hispanic population in Sussex County maybe a little bit more pressing, and explains there may be some, that may be a particular area to look at. Moving on to assets, this specifically looks at home ownership. For many seniors, their primary asset will be their home. So the differences in, first off, who owns versus who rents is significant. Now these are national figures that show sort of the biracial or ethnic group and then their home ownership rates. There was an observable drop in terms of how specifically the Black population in the United States, how many of them own homes versus didn't. This is, I guess, fortunately, this is not seen in Delaware in terms of the Great Recession having the same impact as shown by this table here from the Urban Institute. However, the trend is that there is still a large disparity between white and ethnic and racial minorities in the state, which suggests that both in terms of income, but also in terms of ability to draw on assets, there's going to be issues with funding services, or at least that's what that could suggest. Moving on to just general housing type, these are some, I'm blanking on which organization produced the survey, but just noting in terms of housing location and housing type, this is mainly in regard to predominantly Black neighborhoods, but they tend to have higher rates of poverty, lack of access to healthcare and other essential services such as pharmacies or grocery stores. Infrastructure tends to be more poorly maintained, and there also is a lack of accessible housing. So accessible housing is something that Delaware is in active consideration of how to address. It's beyond the scope of this subgroup and the working group actually, but it is on the radar for future endeavors. And as I will say that as we're making recommendations in the subgroup, and by we, I mean you, I would strongly suggest to think not only within necessarily immediate services, but if there are things outside of it, please include it, because that can be included in the broader report and can potentially inform action down the road. But again, the main point here is that high levels of racial segregation, residential racial segregation in the state lead to disparity that have impacts on social, that contribute to social determinants of health and disparate outcomes in those regards. And then lastly, some points about this is racial disparity in health, and then health is sort of something that's been maybe glossed over or hasn't been taken into full account because they are very intrinsically linked, but these all have kind of rather implications for how well individuals can age. So mainly higher instances of non-communicable diseases, stress related to overt and or structural racism, varying degrees of, and Julie touched on this, trust is something that was mentioned, and again, underscores the importance of cultural competency and thinking about how to adapt services and make services as open as possible to as large of a number of people as possible. And then also this point about higher instances of dementia, specifically for the African-American population in the state. I thought this figure here was rather frightening. I guess this linkage between education, but then also the race stratifies that. So again, I think moving forward, really trying to call attention to the fact that in memory care, we should be thinking about it in terms of how to close that gap. And then lastly, this is a figure here that shows just overall life expectancy differences within the city of Wilmington, and the darker purple areas are neighborhoods with higher African-American populations. And as you can see, the darker purple areas also coincide with lower life expectancy, which again underscores that impacts individuals' ability to age well. So then finally, I tried to distill some considerations for your consideration. So one, social determinants of aging well appear to be really strongly linked to broader topics within social determinants of health. So it may be worth considering how to sort of make the social determinants of aging well part of a larger conversation on the social determinants of health. The economic disparity between racial and ethnic groups in Delaware is noticeable and significant. Again, this is not solely related to social determinants of aging well, but it should be taken into consideration moving forward. The higher instances of non-communicable diseases get linked to higher instances of physical disability. This has implications for services and also need for services. So maybe, again, upstream thinking, but ways to, it wouldn't be beyond the pale to consider calling for more preventative measures to promote healthier lifestyles. Again, referencing the SHINE program, it sounds like there are works underway, but drawing attention to that may be worthwhile. The point on racial residential segregation, compounding racial disparities, this can be used for bringing in broader calls for basically practices such as maybe redlining or anything like that, could be within the scope of recommendations made by the subgroup. Trust, this is a big one. Again, it sounds like Disparity is aware of this, but it could be worthwhile to shine a light on that and really underscore the importance of trust in cultural competency. And then, in terms of, and then the dementia component, again, shining a light on that. And this is actually one that wasn't addressed, but I found it interesting as I was combing through those resources, that SNAP participation is less than half of those eligible. So potentially looking into why that is the case. This is a national figure. And it unfortunately wasn't disaggregated by race, ethnicity, but looking into that as a potential factor. So for why that may be the case. Is it stigma against the SNAP program? Is it lack of information on the program? And that contributes as well to the topic on food security or insecurity. But that about covers it. I'm happy to answer any questions or also provide any more detailed information and point you to where in those resources I found that information. So thank you.
Well, thank you so much, sir. This is a lot, like you said, to distill. And I think these are discussions that many of us have woven into our meetings so far, or things that we're aware of, but this is critical and key. Some of our work on recommendations previously, where we started discussing in this group workforce and transportation in order to affect these areas, are where we started, but your recommendations here are really key. We've talked certainly about what you highlighted here, food deserts and food insecurity, and the importance, like we talked about today, and you highlighted about getting upstream of that with the SHINE program and other efforts. I think you highlighted for us as well, like you called out just now, the just overall health prevention and promotion that we need to do in areas to ensure health equity. So I'll stop my comments there, because you ran through that very excellently for hitting the high points for us. I'm sure others have comments or questions for you. So anyone who would like to chime in, please.
So actually, we have a question from the attendees.
Wonderful.
So actually, I'll. Anne, you should be able to unmute now.
Yeah. Thanks, Will. Can you hear me?
I can.
Great. On the lifespan slide that you showed, I noticed that that's only like representative, it looks like, of the Wilmington area. Do we have data on lifespan, like broader throughout the state? Because that's pretty significant. Like, what would Sussex County look like for Hispanic population, perhaps?
Sure. So I unfortunately don't have the data available, but I do have the means to get that data. It was this was a prepared feature on the city of Wilmington from one of the institutes here at the University of Delaware, actually coincidentally from the building I'm sitting in right now. So that was more of a convenience thing, but I have access to all the data sets. I can run that, and I can get that information for the subgroup, the working group, and provide that to anybody who's interested.
Great. Thank you, Will.
No, absolutely.
Anne, thank you. And for those of you who don't know Anne, Anne is our one of our great leaders at Christiana Care Home Health, heading up the team there. Anne, thank you for your comment, for joining. Anyone else? Okay. No, I'm sorry. That's Anne's hand. Will, one of the other things I think that was interesting, that you mentioned redlining, and some of the things that you also highlighted here for our committee, to get upstream here. And I know that the state is talking and looking about this is education, right? And how we can support that, but also, are there home ownership programs, or are there assistance programs? And when I was Melissa Smith from the director of Disparity, who couldn't attend today, we were talking a little bit in preparing for this. Certainly, we have waiting lists for many of our housing assistance programs, and we touched on it a little bit with our co-chair, Kathleen Purcell, when we kicked off some of our meetings and the programs that they have through the Wilmington Senior Center. But can you talk to us a little bit more about some of the research there? We might be able to develop a recommendation in many ways around the actual housing, home ownership, or the existing programs.
Sure. So unfortunately, housing is not my area of expertise. However, a former colleague of mine is actually, I can't remember a specific title, but she's within Delaware State Housing Authority. So I'll reach out to her and get kind of an overview of available programs, and ask around the office and see what I can find. Don't have that information immediately offhand, but I'm happy to help fill that in.
You're highlighting that. Okay. Anybody have comments from that?
I would just add that we're looking at, we do a home modification program within DSAPIT where we will provide a ramp or something like that in order for someone to age in place in their home if they own the home longer. And we're looking at expanding that program and working with Habitat for Humanity and their Healthy Homes program. And so just like Melissa said, we are really looking at upstream and working with people. But of course, you would have to own your home. And that, I mean, we saw that here that does affect people that we work with who don't own their homes. And so trying to figure out how else to help them to ensure that their homes are accessible, even if they don't own their homes.
Thank you for that, Julia. I'm sure there are other providers as well. I've heard of aware of a program, Good Neighbors, as well, doing similar work in Newcastle County. So is that a potential recommendation for our committee, perhaps, to support those efforts? Put that out there to the group for consideration. Will, were you going to chime in? And Anne, I think I see your hand up.
No. I don't have anything to add.
Okay.
I'm happy to add, although I think, Chris, that sounds like a really good point, but I am here to support.
Appreciate it. Anne, did you have a comment?
Yeah, hi, Chris. And sorry I didn't introduce myself before, but thank you. I'm the Senior Vice President for Home Health and really happy to be here. Julie, I love the work that you're doing in dementia. It's incredibly important, very passionate for me. My mother passed away from it about 4 years ago. So just around transportation, for dementia populations, one of the things that I have heard feedback on is the DART transportation, although it's available, sometimes those members are on the transportation for long periods of time, and that doesn't really work well for them with their illnesses, especially those that have moderate dementia. And that might be something, I don't know if that's something that we're looking at from a state perspective.
Yeah, definitely. That is something that has been brought to our attention before. And so part of the dementia-friendly Delaware efforts would be working with DART paratransit. And the national model, Dementia Friendly America, actually has some really good tools for public transportation providers. And so it's definitely in our plans to work with them and figure out opportunities so that people with dementia can still partake in using paratransit when possible.
Thank you.
Thank you. Do we have any other public comment? Anyone else with us who has a question or a comment? Not seeing anybody.
Actually,
Bill,
Chris,
yes, sir.
I'm so sorry. This is just out of convenience because this is something I've been quite curious about. Question for anybody in the SAPID. Has the Capable program come across your radar as a potential option for home modifications or anything like that?
Yes, it has. Will. Thank you for bringing that up. So, so you've heard us reference wait lists in the past, and our home modification program has had a lengthy wait list for some time. It's when we have state funds available, we put it towards the program. And when we were looking at revamping that program this year, we did identify Capable. And it is one of the things we're looking at because you work with contractor, you work with other people who really understand accessibility needs. And it's an evidence-based program, which we love. Alicia and I both love evidence-based programs. So for sure, we have looked at it and identified it as something that we would love to do in the future if we have the time, if we have the resources available to us as a division.
Perfect. Thank you.
Thanks for that. Okay. Another potential recommendation. Will, if I may, I think I have the ability to share screen. Is that? I'm gonna try.
Let me just stop the share for.
Okay. No, I don't want to cut you off.
No, you're fine.
I'm gonna try here.
Oh, there we go.
Does that work? Can you guys see my screen here?
Yeah. Yes.
Okay, so one of the things that we talked about with our larger work group was making sure we have some draft recommendations. And for those of you who didn't receive this, happy to circulate it. You've seen our recommendations that were provided for us from Will and in the memo that he circulated. And so I want to point out that I think there's a lot of great substance there. I took a stab at this and kind of in spirit of, I think, Rob, where you were before trying to draft something, you know, for what are the goals of our group here. And so what I think we will kick around as a team in the next few minutes, but also between our next larger work group meeting is a draft. And I think there's potentially a lot of amazing background to supply from our previous discussions and our subgroup work and the memo that Will provided to us that might help frame our discussion and recommendations. Here is our subgroup, and I don't know if this is the format, Will, that the rest of the teams will do, but you know, we're recommending the following, and we're recommending that we support aging in place in Delaware by addressing the social determinants of health with measures that will address racial disparities and provide health equity. And I think where we started off with our goal is, you know, where can we recommend that the state invest? So I used the word investment. We talked a lot on this work group about where gaps in services exist, or perhaps we want to say where there are disparities. Where we know there are existing programs that we think should be strengthened, and where there are innovative solutions or things like the capable model, local or national models that we've seen that we should recommend that have evidence-based success. And so what we've talked about before in looking at where we would recommend investment, certainly in his workforce capacity, like we mentioned before earlier, reimbursement rates, so that we have the teams to be able to meet the needs. We highlighted and talked about, Anne, your most recent comment, access to transportation, and we do have another subcommittee, or subgroup that's looking at that, specifically where there are disparities. We talked about volunteers and the importance of those programs that we've heard as well in transportation, also Meals on Wheels. Talked a lot today about addressing food insecurity, memory care programs, dementia-friendly communities, family caregiver support, and also potentially housing assistance programs where we know there are waiting lists, or like we talked about, home modifications. So this is a draft. Here we have 2 minutes left in our committee meeting. Would love to hear some initial feedback or thoughts. Rob.
Can we actually pull that? Can you actually share that screen again?
Yes.
If we're going to edit this in real time with 2 minutes, maybe we should just keep it up on the screen for a second, if that's okay.
And you see it again now.
It is loading. Yeah. Can I just make one recommendation? It's I think a small but meaningful one, and that is replacing the word investment with support, because this body is not a budget like advocacy body necessarily, right? And if there are certain places with specific asks related to budget, fine. But just like generally speaking, I think most of this probably requires further research or data or whatever, right? And so rather than just kind of pointing directly at money, which, you know, of course I'm happy to do for provider rates, but that's like my full-time job, right? Like I have a boatload of data to support that stuff. I don't have a boatload of data to support the other stuff, which I'm not saying it doesn't deserve investment, but given that we're not all experts on everything, it might just kind of be a better catch-all for the legislature to just use the term kind of support. And so in their research, you know, it can be up to kind of true experts on what that support really means and looks like. Does that make sense? Sorry for being so politically correct.
No, that's great. That's excellent. And that's how we should frame that, and appreciate others' perspectives. So thanks for that, Rob. Anyone else? Anne?
Yeah, hi, Chris. I would recommend that we consider something around racial disparities for life expectancy. I mean, that was pretty glaring in Wilmington, and I would also be interested to see, you know, throughout the state as well.
Mm-hmm.
Anne, are you aware of any kind of annual reporting that has to be made public on that? That might be like a good, not that the state needs yet another annual report, but a lot of the problems in our state is that you can't find a lot of this data like particularly easily. And it strikes me that that kind of demographic info, we were talking a lot about making people aware of things. That would be a great one to make people aware of.
Yeah, I'm not aware of anything, but I certainly can ask around and see if there is. You know, particularly, I've noticed some concerns around the Hispanic population down in Sussex County with access to care and other, you know, concerns around there. So I think we should definitely take a look at this more closely.
And also I can just chime in quickly. So that initial map was made through a tool that used for it captures Census Bureau data and then like geocodes it onto a map. I have access to that tool. I can go through and should be able to pull that data and have a maybe not nearly as pretty of an image, but can definitely inform that conversation.
Yeah, you know, William, and Chris, I might add just to this list, and please, again, I'm not an expert if such a report already does exist, but you know, a good way to keep these on the docket is maybe there needs to be like an annual narrative, like a report that kind of updates the data and makes it available to the legislature and available to like identified key stakeholders about, you know, racial disparity issues related to home and community-based services just across the board, right? And the recommendation here is not that that needs to be done this moment, but that there should maybe be a conversation about what such a report would look like.
Thanks, Rob. Appreciate that. Carolyn?
Okay, I just want to say, number one, I'm so glad to see that reimbursement rates is number one on the list because that's extremely important. And I also am very concerned that we get a lot of our funding to reimburse our Meals on Wheels volunteers. And if we didn't have them, we wouldn't have a home delivered program. And they're looking for an increase in mileage reimbursement. And right now, even from this day to the end of my budget year, I'm already going to be $10,000 in the red with just keeping them where they are right now. Now, I think I can go back to JFC and talk to them because that's where we get a lot of our reimbursement rate from. But I'm also concerned there's $15 million increase in the nutrition program. That's sitting on the president's desk right now for it to be signed. And I don't know how that percentage breaks out into Delaware. I know we get a certain percentage. I'm asking if that percentage, Delaware's percentage, come back and go back to the providers that are actually in the trenches trying to, you know, deal with the increased food and fuel and every other kind of cost. So whatever comes back to Delaware for the nutrition program, I'm hoping they put that back to the provider. And I cannot go without saying what a terrific, I know you guys have talked about the Modern Maturity Center today, and I could not do any of it if I did not have the support of the division. And so I thank you all so much for helping me out.
Thank you, Carolyn. Appreciate that. Thank you all. Anne, I think you have a comment or question.
No, forgot to lower my hand, Chris. Thank you.
All right. So thank you all for letting me share this. This was my trying to get the ball rolling, and I appreciate those contributions. And Will, I think we have some work offline to do that I'll connect with you to incorporate your recommendations. I want to thank everybody. We are 5 minutes over our official time. And once again, Will, you were right. We could talk on this. Could have reserved a whole nother half an hour. I want to thank you, Ishan, for hanging on and with us and making sure that technology is working here. And so with that, I think it would be a good time to close out with what is our plans for our next meeting. And Will, do you know the calendar yet for the larger group?
Yes. So
yeah,
the next meeting, the larger group, will be April 8th, which is a Friday. That will be when the initial draft of the final report will be presented for consideration and debate. And then after that, the last meeting of the larger working group will be April 22nd, I believe. So it's 2 weeks after that April 8th meeting. That'll be the final where, you know, the vote to approve the final report.
Okay. Thank you for that. What is the recommendation or pleasure of this group? Do we need to have another meeting before any of those to discuss and perhaps finalize some recommendations? Will, do you know what other subgroups are doing? Are they looking for one more?
Actually, this is the first of the round, if you will. So I'm not entirely sure what the plan is on that. Also, I can alternatively, if scheduling a meeting is difficult, an alternative could be to put into a common shared document, like a Google Doc, to make kind of minor alterations if that's the route the subgroup would like to go.
That would be a great start. I just, there's so much to discuss here, and we could, again, spend a lot of time, and I want to make sure we do justice to our recommendations. Rob, Carolyn, Allison, and what are your thoughts on, do you want to bring back together for another meeting for further conversation?
I certainly think there's room to have a discussion about kind of what it all means after this, right? Like, certainly if we're going to be putting forward a set of recommendations, I for one would like to see the final product before you actually send it over. If it's supposedly going to have my stamp of approval or this group's stamp of approval, and perhaps a real chance to finalize the order of things. Yes. I know this was sent in advance, but I kind of anticipated a little bit of more discussion on it first. Yep. So maybe next time we can just kind of nail that down, and then I don't think it should take an hour and a half.
My suggestion would be that we schedule a meeting in between the 8th and the 22nd. So after the full group meets, then we'll know a little bit about what they're going to be talking about, and then so we meet in the middle.
That would be wonderful. Will, can you help us coordinate that, please?
Absolutely. I'll send that out right after we get off here, or well, by the end of the day. Let's put it that way.
All right. And thanks, Anne. Anne, you had a comment too.
Yeah, I agree with everyone. I think more discussion would be helpful.
Great. Thank you. Just wanted to take the temperature. Anyone have any other final comments or questions? I appreciate your extra 10 minutes then. Thank you all so much. Thank you again to our team at DSAPID and all of our providers on the call here. Thank you for all that you're doing for our state and our community and our family and friends. So
thank you.
Feelings mutual, Chris. Thanks for hosting.
Bye.
Thank you.
Bye-bye.
All right. Take care.
Recording stopped.